Okay, we'll go ahead and get started then. Welcome, everyone. Thank you so much for joining us this afternoon for a webinar on vaccines and dystrophinopathy, building protection. We are thrilled to have you here to dig into all of your burning questions about vaccination in Duchenne and Becker. And we've got a great group of speakers. But before we dig in, I want to offer a special thank you to the grandparents group here at PPMD. And some of you may or may not be familiar, but PPMD is really thrilled to bring together different groups of people and offer opportunities for engagement and connection. And one such group is our grandparents group. And very recently, from that group, we were brought the question about vaccination. What does it mean? How does it work in Duchenne? How does it interplay with pulmonary care, with clinical trial participation, with steroid use? And we realized that these were great questions that should be brought to all. So we thought, it would be an awesome opportunity to have a community webinar really focused on this topic. And in addition, we've also updated a lot of the resources on our website. So if you navigate to the vaccine portion of the Parent Project Muscular Dystrophy website, you'll see all sorts of new information, resources, guidelines as it pertains to vaccination in dystrophinopathy, all of which was reviewed by the fabulous group of speakers that we have with us today, including Dr. Anne Pham-Huy, who is a vaccine expert who comes to us from Ottawa at the Children's Hospital of Eastern Ontario. And she's going to kick us off today just talking about the what's what of vaccines to help sort of lay a groundwork and a framework for today's presentation. As she speaks, if you have questions, please feel free to drop them in the chat and we'll get to as many of those questions as we can at the end of the hour. And with that, I'm going to go ahead and hand things off to Dr. Anne Pham-Huy.
Hi, thank you. It's such a pleasure to be here. I wish I could see you, and I imagine us being in this cozy room and having a chat. I'd like to talk today about vaccines and specifically optimizing health and immunity in those living with Duchenne and Becker muscular dystrophy. A quick disclosure, I did receive an honorarium and a travel support from CSL Behring to give a talk that is unrelated to today's topic on the severe combined immune deficiency. But mostly I'd like to talk about some of my perspective, and I think it's important for, next slide, the group to know where I'm coming from. So as mentioned, I work in Ottawa, in Ontario, in Canada. I'm a pediatric infectious disease specialist, and I also work in clinical immunology. So the bulk of my practice, I see children with really severe infection, and unfortunately some infection that are preventable. I also see lots of patients and children with different conditions that make their immune system weak. And with that, I have got myself into the world of vaccines, really understanding vaccines, how they work, how to optimize them, how to ensure that they're safe. So we we have these clinics in Canada, and I think there's some in the US called the Special Immunization Clinic, where we see children or adults with potential side effects after a vaccine, but also children and youth who've had maybe more complicated schedule needs or complicated vaccine needs that needs to be assessed by a consultant. And with that, I wear certain hats with Immunize Canada, which is a coalition of various organizations to promote and educate about vaccine. And I sit on the National Advisory Committee on Immunization. So in the US, this is the equivalent of the Advisory Committee on Immunization Practice. But at the core, I am a mother. I have two kids, and they have been optimally vaccinated, I hope. So let's start right now. And we'll go through a lot of different principles and foundational knowledge just to kind of set the stage. So that's my goal, is to set the stage for the listeners. And then you'll hear from two specialists very specific to Duchenne and Becker. So I think understanding your immune system and the impact of vaccine is key. Vaccines are among the greatest public health achievements in the last century. It's a core part of being a healthy person and also part of a healthy community. Now, there are many types of vaccines, and that's a good thing, but it might make things a little bit complicated for families, but also for healthcare provider. So understanding vaccines is really important to better appreciate the benefits and the potential risks, the real world impact, like how it works on a population, but also to understand how it can help your own child. It also helps to dispel some of the myths or misconceptions that are circulating regarding vaccines. Next. So, as I said, we are setting the stage and we'll go through some general principles and key understandings. So we'll start with the immune system. So I'm biased. I think it's like the most important system of your body, but think of it as your built-in defense system, and it has multiple layers, multiple parts. Essentially, it's like a group and a big network of different elements to protect you against things that shouldn't be in your body. It could be infection, it could be damaged cells. It has a lot of guards and surveillance and barriers and walls. It has specialized agents. It has a repair crew. So it's quite sophisticated. Next. And it's also quite complicated. Next slide. So if we had to map out every single pathway of our immune system, I don't know if it'll look like this, but it is complicated, but it's also quite humbling to learn about the immune system, and it does a lot of things without us even realizing. Next. So just to simplify things, I'll just divide the immune system into two parts. We'll talk about the innate immunity and adaptive immunity. So innate immunity is kind of your operating system. Everybody's born with it. And so luckily, every baby is born with an immune system. Even the ones we sometimes say, oh, they don't have an immune system, they actually have an immune system. And so this will include all your barriers, your chemical barriers, a variety of different cells that are there to kind of protect you. It's kind of that system that is, fairly good, fairly fast. It may not have all the specialized memory or recognition, but it is very important and useful, and it works well. But now we have the adaptive immunity. So that's the part of the immune system that actually needs to learn and to protect us more specifically. And in adaptive immunity, we have two terms that we use. It could be active immunity, where our immune system is really actively making this immune response, versus passive immunity, where we are providing pre-made, for example, antibodies. So in active immunity, we can acquire that through having encountered an infection naturally, or just, by exposure, or through vaccination. So vaccination is a type of active immunity that stimulates an adaptive immune response. In terms of passive immunity, an example might be maternal antibodies. So in utero, during pregnancy, the mom will pass on her healthy antibodies over to her fetus to protect the baby in the first few months of life. There's also artificial types of immunity, where there are medication where we have pre-made antibodies. So we'll talk in more details, but for example, some of the RSV vaccine are actually a form of passive immunity. Next. Okay, so now we have an idea of the immune system and some of the big components. We appreciate that it's complicated, but very sophisticated and useful. So let's just walk through what happens when you get infected. So this is a virus. So there's a lot of animation. So just follow with me. So this is a virus. He's not nice. This is you. You breathe in the virus through your nose. Because viruses, they need to enter somehow. So the majority of the times, and there's different types of infection, but one main way of acquiring infection is through breathing or entering through mucosal membranes, or eyes, nose, your gut, things like that. And then after that, the first thing that this virus will encounter is your initial, first line protection. This is what we mentioned is the innate immunity. So there's a collection of cells that are part of the innate immunity. And usually in kids, it's fairly robust. And if it works out well, and there's not too many viruses, then usually that's enough and it'll clear your infection. So for example, next. So this is your infection and no infection. So this might be, I don't know if it happened to you, like where you wake up one day, you have a bit of a scratchy throat. You're like, oh, I think I'm going to be sick. And then a few hours later, you're like, oh, you're fine. So that's your innate immunity working as it should. But sometimes you may have breathed in more infection, or it may be the first time you encountered this infection, so you don't have a lot of priming. And then the virus can then have a bit of a party in your nose and replicate into many multiple different viruses that make more virus babies. And then you need a bit more help. And this is when you will activate that other part of your immune system called the adaptive immunity. And this also has a whole series of helpers, the lymphocytes, where then some of them will then go on to make antibodies. It'll make nice antibodies that recognize that specific type of virus and will try to bind to it, neutralize it, and get rid of it before you get too sick. But it takes a bit of time to make these antibodies for the first time. And so you may, be a bit sick while you're in this stage of your immune response. Another important aspect of your adaptive immunity is that you want to remember. You want to make sure that I don't want to go through this illness or sickness again. And so part of the adaptive immune response is to create memory. And so you will go from like not feeling so good and then finally resolving, and then you're all better. So this is like kind of a normal progression. It's a bit more complicated than that, but it helps you understand the different process or stimulation of various parts of your immune system. So the question is like, what if we could just avoid being sick or at least having severe infection or severe disease? Enter vaccines. So the next few slides is just to go over a little bit how vaccines work. So with vaccination, the main goal, what we're trying to do is to train or stimulate our immune system to recognize a pathogen or an infection, and then mount this adaptive immune response before you encounter. So recognizing, remembering, preparing, all those are features of the goals of vaccination. So what happens, you get vaccination. If you recall that first few slides, this is part of active immunity because we're going to ask our immune system to mount this response. And so we get a special aspect, we'll go through what it could be in the vaccine that then stimulates our adaptive immunity to create these antibodies as well as memory, right? So we're kind of like trying to train to mimic an infection without feeling sick. And this is kind of the basis of vaccination. Next. All right, this is a super important concept and slide. So immunity training, think of it as like if you were training for, I don't know, anything in life, in a marathon or recognizing something. And so the goal of immunity training or vaccination is to have a faster and a better response. So if you look at this graph, you'll see kind of on the y-axis, the antibody concentration, so how much antibodies is produced in your blood, over the x-axis over time. So the first exposure, in this case, we'll pretend it's a vaccine. So you get a vaccine, you get priming of this immune response, and you get what we call a primary immune response. So you'll see there's a little bit of a lag. The antibody response goes up as it should, and like any antibodies or many antibodies, sometimes the dose goes down over time, especially if it was just the first encounter. But this is where the beauty lies or the magic lies. Once you get a secondary exposure, and this secondary exposure could be the actual infection, once you get exposed, your immune system say, hi, I know this. I've seen this. I've been trained about this. And then they will mount a faster, more robust, more effective immune response in order to clear or deal with the infection. And so you can see the rise of antibody is much higher, much faster. This is also some of the principles for booster vaccination. So sometimes one dose is not enough and you get another dose to kind of enhance or create this secondary immune response. So again, you're training the immune system to recognize and fight a specific pathogen before you encounter it. And this way, when you actually get the disease, some people may actually have no symptoms, or if they have symptoms, it's mild symptoms. But the key feature for the majority of vaccination program is actually to avoid complications from the disease or death. So the more severe outcomes. So vaccination is not a full shield. It's not but it's definitely very helpful to prevent these more serious complications from infection. So this is what we're aiming for, is to be very happy like this boy who's, is vaccinated. Next. All right, so now that you have all this knowledge, we'll go through again some general principles of the different types of vaccines that we have. Like I mentioned, there's increasingly different vaccine platforms, designs, and all that. So it's important to kind of understand that there are different types. They have different roles, different goals, potentially different benefits, different side effects, etc. So again, to simplify, I'm going to give you two categories. So first is the non-live vaccines. So if you can see the images, you will recognize that these are pieces of a car, but you also recognize that there is no way this car is going anywhere. So these are non-live vaccines, which make up probably the bulk of the vaccine types that we have. They're actually non-live. So you cannot get the disease from the vaccine. It is 100 million times impossible. Then the next category is the live but attenuated vaccines. So sometimes we have bacteria or viruses that we have weakened. We've had made so weak that it cannot really do what it should normally do. So you will recognize that this is a car that it can roll and be driven around. I'm not even sure if that is an adult or a child, but anyhow, it's a car. But I will tell you that it doesn't go very fast or very far, but it functions. So this is the concept of a live weakened or live attenuated vaccines. And we have a few vaccines who are excellent, but they're in this category. As opposed to the real deal infection, this is what a natural infection may look like, right? So next. This is, just again to characterize the differences between non-live vaccines, live vaccines, and then natural infection. Although some people may say, I want that car. No, you don't want that car, okay? All right, types of vaccine. We have a lot of different types and vaccine platform. They have their pros and cons. I'm not going to go through all the details of it. I think I just want people to know that there are different types. And so sometimes I hear, some of my patients and families think that everything in life or every vaccines are live, but they don't. And so some contain just parts because again, you're trying to teach you're going to teach the immune system, so it could be a little component of the pathogen and not the whole pathogen. So we have live attenuated vaccine, inactivated vaccines, toxoid vaccines, again, to kind of show a toxin, not the whole bacteria or virus. Nucleic acid vaccines, where we're providing the recipe for our cells to make something that's part of a pathogen, but doesn't last. Viral vector vaccines, subunit vaccines, conjugate vaccines, etc. Next. So why are vaccines especially important in Duchenne Becker muscular dystrophy? Well, children with Duchenne and Becker actually have a normal immune system. And so their immune system works perfectly fine. They have innate immunity, they have adaptive immunity. But over time, some children will have progressive muscle weakness, and that can affect the breathing muscles. And that makes it harder to clear infections, mainly lung infections. And so the lungs can become fragile and more vulnerable, and we really have to do our best to protect them. As part of treatment, certain medications are provided as standard of care, including steroids, and those can also decrease the immune system, making infections harder to clear. So preventing infections in general is a good idea for these children. Next. What happens if you give a vaccine to someone with a weakened immune system? And again, you can be weakened because you're born with a weak immune system, but you can also have a weak immune system because of medication or other treatment. So again, general principles, the questions that we always ask is it safe and does it work? Next. So it requires, and this is the key thing, a precise but regular assessment of risks and benefits. We want to vaccinate when the benefits are high and highest in the sense that when the immune system is working really well and so you can have the best immune response. And we want to give it when the risk is at the lowest. Next. So when should we vaccinate? I always talk about the window of vaccination. And so you want to vaccinate early in the disease before exposure. So ideally, obviously, if you've already encountered the pathogen or the infection, then you've already done that primary response. You want to do it before, and you want to review immunization really routinely. So at diagnosis, but also at every visit. You want to do it in general, if possible, prior to starting immune suppression. And we have different cutoffs depending if it's a live vaccine or a non-live vaccine. And if you are on immune suppression, then if we know that the immune suppression can be decreased or taken off, then we may want to wait for that. And then I'll go through a little bit more in the concept of the level of immune suppression. Next. All right, so again, it's a balance, and this can change over time. What is the person's immune system, net immunity versus how much drugs are given that actually suppresses the immune system. Next. So this is an important slide that I won't spend too much time because you'll have experts specifically for Duchenne and Becker talking about this soon. But I want people to kind of like realize that there is a concept of the level of immune suppression. Sometimes we consider people immunocompromised, but again, is it high level immunocompromised or low level? And it really depends on the drug and the dosing of the drug. So high dose, more immune suppression, lower dose, lower immune suppression. So I just kind of put a few regimens, but again, we'll go through it later, I think, with our next speakers. But in general, because of the live attenuated vaccine, there's still something live in it. We do try to avoid giving it when a child has high level immune suppression, which means high dose systemic corticosteroids. Next. Okay, what about pre or post gene therapy? So very, very exciting in the clinical world of Duchenne is the potential of gene therapy. So again, without going to details of how it's done, but higher doses of steroids or immune suppression are used in the context of gene therapy. So again, same principles. You want to give it before you do the gene therapy, before there's increase, and you try to wait for that, look for that window of vaccination. If you are, if you know of a date for gene therapy, then obviously you do it before, which is always preferable. But if it's after, you might want to wait till the immune suppression decreases over time. Next. Okay, and what about vaccinating the household? So that's also a really good question. And I'm going to guess that everyone who's attending here is wanting the best to protect their loved one. And so is it a good idea to vaccinate the household of an immunocompromised individual? Yes, it is. Please do it. You don't know how much you could help. And it's a bit of the concept of a cocoon. So you want to be protecting your loved ones. And so it's not a shield, but it will avoid bringing, let's say high loads of viral particles into your house. So this will include seasonal influenza vaccine and updated COVID-19 vaccine. You're going to want to protect things that obviously can cause lung disease or lung infections. A question I get a lot is that, oh, well, if my child is immunocompromised, can I get live vaccines? Can my other children get live vaccines? So the good news is that any kind of live vaccines can be administered to the household, so the siblings or the parents or whatnot, even though somebody is living with an immunocompromised status or immune suppression. And there's only a few exceptions, which I've listed now. So oral polio you should avoid, but in the US and Canada, we do not use oral polio, so in theory, it should not be an issue. And then we would avoid the live attenuated influenza vaccine, and mostly because we have very good alternatives of non-live that is still very effective. Some minor precautions that are probably not too relevant in this case, but the person that's immunocompromised should avoid handling diapers of infants vaccinated with rotavirus. So that's, again, unless well, I suppose your children could change diapers. Anyways, that could come into play, but it's a precaution. And avoid direct contact with varicella or zoster rash until the lesions have resolved. So you should get it, but if you do develop lesions, then you should just avoid, come into direct contact with the immunocompromised individual. Next. All right, so vaccines are a standard part of maintaining good health, but for everyone, for children, youth, adolescents, and beyond. Next. There are routine vaccination that are really part of routine care. So let's call them the foundation of vaccination. So there's a schedule, it's given at different months. I put on the one in the US and one for Ontario, my province. Next. But for Duchenne and Becker, there are some additional vaccination to optimize the health. And again, a lot of focus on preventing lung infections. So again, this includes seasonal, annual influenza vaccine, updated COVID-19 vaccines. There are new and broader pneumococcal vaccines, again, to prevent pneumonias like invasive pneumococcal disease. There's also some RSV vaccines for infants, but also for those above 18 years. Unfortunately, not for the in-between age, so not for 2 to 18. Next. So take-home message from, I just discovered these 3D models in PowerPoint, so I got fun, so I think it's supposed to move, but anyway. Vaccines are one of the most important tools to prevent infectious disease. It doesn't look as fun when it's not moving, but anyhow. Immunization is an essential part of optimizing the health of a child with Duchenne and Becker. And oh, there it goes. I don't know if you can see it. Sorry. So vaccines, again, they prime and they train adaptive immunity. It helps to create immunological memory for a faster and better response when you encounter the infection. And the main goal in this condition is to prevent severe complications of infections and progression of disease. It really is instrumental in protecting the individual, but also their community. Next, I put a lot of different resources, both in Canada and US for you to see. So I am assuming this will be available somewhere that you can just click and read away. And I think that's all I have for you guys. Okay, I'll hand over to Dr. Taylor.
Wonderful, thank you. That was great. And hello, everyone. My name is Jane Taylor, and I'm one of the pediatric pulmonologists from UPMC Children's Hospital of Pittsburgh. And today we're going to talk about vaccinations and how they help the lungs. So next slide. Why vaccinate? And that is a great question. Next slide. And it's all about keeping our lungs clean. And to do that, we'll quickly talk about respiratory physiology. And that's a fancy word for just saying, how do the lungs work and how do viruses impact how the lungs work? So first off, it's all about the muscles. Next slide. So the lungs themselves help get oxygen into the body and carbon dioxide out, but they can't do it by themselves. The muscles are a very key part of lung function. And we have lots of muscles that help us get the air in and muscles that help us push the air out. And you can see here all the different rainbow colors of muscles, and all of that works together for breathing. Next slide. I like to think of it as the blue arrows for breathing in, and those muscles help the chest wall go up and out. There's also a big muscle called the diaphragm, which is the pump, and that goes down. That's going to help the lungs actually expand out and pull in the oxygen. Now, the red arrows, that's pulling the chest wall down, and the diaphragm pushes up, and that helps get the air out. That sets up the next cycle to get more good air with oxygen in, and then breathe that out as well. And it just keeps going and going. So next slide. This is normal breathing. I want you to focus on the red dashed line. That's the diaphragm. That's the big muscle that goes up and down. It's the pump. But we also have the accessory muscles that are along the chest wall that have it raise up and out for breathing in, and then down for breathing out. Next slide. So you can see when we breathe in, the diaphragm's going down, and the actual chest wall goes up and out, which gives us more room in the actual space where the lungs are. Next slide. When we exhale, that diaphragm is pushing up, and the actual chest wall comes back down. That squeezes the lungs, and the air goes out, allowing us to then take another breath with oxygenated air. So there should be a video. Next slide. Yep, inhaling in and Next slide. Exhaling out. And I can't take full credit for this. My good friend, Oren Kupfer from Colorado, and I put this together one of our PPMD meetings. So I have to give him credit for this as well. But it really does show you how the pump system and the respiratory muscles are helping to get the oxygenated good air in. And then after we're able to take the oxygen to our body, we exchange it with air that has carbon dioxide and we push that back out. And this goes over and over again. So next slide. And what this also helps us do is keep our airways clean. So there's something called the cephalad airflow bias, which sounds super fancy. But then when I explained it to my own children, they're like, oh, well, this makes perfect sense. And it's when you're inhaling, all the pressure is actually pulling up and out. So the lung tissue is also being pulled up and out, and you have a larger diameter. So the airways, instead of being small, are actually larger. This helps the air flow in, and it also tends to flow a little slower. When everything comes crashing down or you're breathing out, that pushes everything pretty quickly. The diameter goes down a little bit more and the air flows a little faster. So any type of mucus or pollen or type of virus or other nasty thing that you don't want to keep down in your lungs gets trapped down in the mucus, which with the cephalad airflow bias then gets propelled up and towards the mouth where you're trying to get rid of it. So next slide. You want to try and get all of that mucus up to the middle airways, where the act of breathing, the respiratory muscles help you cough it up and out. And cough actually is a 3-phase process. You have nerves that are stimulated saying, I need to cough. There's something there. I want to get it out. And you take a deep breath in. That expands your chest wall even more than just normal, regular breathing. Immediately, you start breathing out, but the upper airway closes the vocal cords. So you're building up a little bit of extra pressure. And then when it opens, you get the mucus that comes up and out. And this nice man down below actually had inhaled a little bit of powder so we could take a picture and show what it looks like when you're sneezing or coughing things out. And that helps get things that you breathe in with each breath, because the lungs are open to the environment all the time, up and out, and keeps itself clean, including viruses. So next slide. Now with all of this, you're like, yes, I understand that the actual airflow is important, but Dr. Taylor, besides airflow, what else is there in the lungs that's there to keep us nice and clean? And it really is the mucociliary elevator. And that's a fancy word, but I'm going to break it down for you. And I think you'll then understand that, and then how the viruses impact it and why I dislike viruses. So down in the very, very ends of the lungs, that's where you have these small little round balls called alveoli, and it's paper thin tissue. Very easy to get the oxygen into the bloodstream, and the carbon dioxide goes the opposite direction. You breathe it out. But all of the airways leading to those small little round balls at the very periphery of the lungs, those are the conducting airways. And anything that's out there in the air that you're breathing in can get down into these big tubes of conducting pipes. So our body, over many, many centuries, has developed a very nice way of keeping itself clean. And as you can see here in the bronchioles and bronchus, those are the blue cells. They actually are lined with small little structures called cilia, which for all intents and purposes are hair. So kids look at me and they're like, we're hairy on the inside? And I say, yes, you are. And that is a good thing. We will explain what the hairs do. You also have mucus glands. So you're secreting a little bit of mucus, and it kind of acts like flypaper that's going to catch all of the bugs, all of the dirt, all of the pollen, and also viruses and other things like that in that mucus layer. And then the cilia, the little hairs, their job is to get it up and out. So next slide. So this is just another way of showing that. The pink cells, that's the respiratory epithelium, which is just another way of saying the actual lining the skin of the lungs. They have hair. Those are those little black kind of swivels. Those are called cilia. They act like guys on a rowboat, and they're actually in a layer of liquid. I like to call it a saltwater swimming pool. And they're rowing. They are rowing up towards the mouth. And the mucus, which your body produces, is sitting on top of that saltwater swimming pool. So the cilia start a current that moves it all up and towards the bigger airways where you can cough it up and out. So next slide. And there we have our cilia, which are the rowers, and that helps swim the mucus, which acts like flypaper to catch all the bad stuff, up and out towards the mouth. So next slide. What happens when we get a virus or we get a respiratory illness? And you actually increase the amount of mucus that you are making. So there's a lot more that your body needs to get up and out. So the cilia is doing extra work. There's also inflammation of the airways. So you saw in my diagram, everything was nice and flat. So it's like in a farm field in Kansas, if you look out at the corn, you can see the wind for like miles just easily going across. Now that I have moved to Pittsburgh and I see all of the lovely hills that kind of go up and down, that's what happens to the topography of your lungs if you get a virus. It's hilly because of the inflammation. If you were to look at wind going across a field that is hilly, you're going to notice that there's lots of movement at the top of the hills, but in the little valleys, nothing's moving. It's getting stuck. And that's how you can then start to trap mucus, and that increases your risk for infection. And then also with certain viruses, especially influenza, which I particularly hate, it damages my cilia. So my poor little rowers are not able to row well. And in very severe forms of influenza, sometimes the cilia actually fall out and you have to regrow them for about a month. So for a month, you're at increased risk for secondary bacterial infections. Cilia are in your lungs, but they're also in your ears, so at risk for ear infections and your sinuses. So definitely viruses are not friends of the respiratory system. Okay, next slide. So this is the big kind of X. Viruses want to knock it out. And that's why vaccines can be very helpful in protecting the cilia and protecting the mucociliary elevator, as we call it, to get the mucus up and out. Okay, next slide. So what vaccines do we have that help prevent respiratory infections? And we have influenza, COVID-19, RSV, and Streptococcus pneumoniae, which is strep pneumo. So next slide. What about the flu shot? And this is, it comes in two different flavors. The first one is the inactivated vaccine. So it does not contain a live virus. And this is what we recommend for our neuromuscular patients. It's approved for 6 months on up. And the first time you get it, you do need that booster. But after that, it's a yearly shot. And there also is a form, which is like the Flumis or the intranasal vaccine. That's a live vaccine. So it has very weakened viral particles. And we do not recommend this for our neuromuscular patients. And this is also where anyone who lives in the family of one of our neuromuscular patients, we try and highly encourage them also to get the inactivated flu shot. Okay. COVID-19. So this is approved for 6 months on up for the Moderna and the Pfizer BioNTech. And that is where you also will need one vaccine and then a booster afterwards. So 2 initially and then 1 after that. For 12 years on up, there's the Novavax that also has been approved. And this is something that, you know, families have to decide on a case-by-case basis, but I do recommend it for my patients. Next one, RSV. So RSV is also another virus that can be particularly aggressive for younger children. And we do have a vaccine. It is called Abrisval, and it is for high-risk patients between the ages of 50 to 59, but 60 on up, you are eligible. And then pregnant women between the gestational ages of 32 to 36 weeks, also eligible. And this is something that if you're a grandparent, you could get this vaccine and help protect your young grandchildren from potentially being exposed to RSV. And if you're pregnant and you get it within that time frame of the 32 to 36 weeks, you'll be producing antibodies in your breast milk that could help protect your newborn. Now, for kiddos up to about 2 years of age, we have immunoprophylaxis. This is not quite the same thing as a vaccine. It's a monoclonal antibody. So we're taking antibodies that have already been made by another person's immune system, and we are cleaning it up, making it safe, and then giving it to the child. This is something that over time wears off, and the child will not have their own immune system react to it. So for the first one that we had, it was called Synagis or palivizumab. This lasts for about a month, so you would have to redose it on a monthly basis during the RSV season. Usually around Pittsburgh, it would start in October and go through March. Now, we have some newer versions that are able to last a little longer. So we have Beyfortus, and it lasts for about 5 months, so you just need it once. And then we also have a new one that just got approved called clesrovimab, and that also is one that lasts for about 5 months. And infants less than 8 months of age, or high-risk infants 8 months to about 19 months during RSV season. It does not explicitly say neuromuscular patients for this vaccine. However, it does include children who require medical support, have abnormalities on chest imaging that persist when stable. So in my patients that have severe neuromuscular conditions and have persistent atelectasis or very narrow chest walls and kind of differences in the structure of their bony rib cage, I'm able to get this vaccine for them. Next. And then we have the Prevnar boosters. And this is for a bacteria that causes pneumonia, specifically necrotizing pneumonia, which tends to eat away at the lung tissue. So we really do not like this bacteria. And especially after influenza, when there's not as many cilia helping us get stuff up and out, you're at increased risk for more invasive bacterial infections. And that's why I encourage all of my kiddos after they get this as the standard routine childhood vaccine series, we then, once they are teenagers to young adults, they can get boosters. And when they're children, it's the Prevnar PCV13 vaccine series. But for teens and young adults, there is a booster. It's the Prevnar 23 or PPSV 23. And that's something that you can get at your pediatrician or internal medicine, family medicine doc's practice. We also have 2 newer versions that are also made for people that might not have gotten their initial Prevnar 13 series. And that is the Prevnar 21, or there's one called Prevnar 20, which can be particularly helpful if you're living on the West Coast or have Native American heritage, because you could be at increased risk for certain types of the strep pneumo, especially subtype number 4. So those are the vaccines that I talk about the most in my clinic as a pulmonologist. And with that, I'm going to pass it off to Dr. Matesanz.
Awesome. Thank you to PPMD for having me. Thank you to Dr. Taylor and Dr. Pham-Huy for their fabulous talks. My name is Susan Matesanz. I am a neuromuscular neurologist at the Children's Hospital of Philadelphia, and I co-direct the PPMD clinic at CHOP. Next slide. So Dr. Pham-Huy touched on this a little bit, but most of our boys and young men are on steroids with with Duchenne muscular dystrophy. And so when are you considered immunosuppressed? And so typically it's when you're on either 20 milligrams or more of prednisone or 24 milligrams or more of deflazacort. I like to think about this, who does this apply to? So based on kind of the weight-based dosing that we use, this would apply to anyone who's above about 60 pounds, who's on kind of standard dose ranges of our steroids. And as Dr. Pham-Huy mentioned, those who are on weekend only or intermittent prednisone or deflazacort are not considered immunosuppressed. I'd just like to highlight the fact that we do now have a third steroid option, vamorolone, and this is still new, and so less is known about the exact immunosuppression of vamorolone. Next slide. And the purpose of this talk is not to go over steroid regimens, but I did just want to briefly highlight kind of our 3 steroid options that we have in our armamentarium and the different starting doses. And then as you can see, the weekend only dosing is only possible with prednisone and deflazacort at this point. And so these are some of the things we're just thinking about as we're getting ready to start steroids. Next slide. And so what are some of the unique features that we think about, like that I go through with my patients as we're getting ready to start steroids? And so I just like to highlight that the MMR and the varicella vaccines are both live vaccines. And so as Dr. Pham-Huy highlighted, we typically want to give live vaccines prior to being in an immunosuppressed state. And so, per the CDC vaccine schedule, typically the second dose of both MMR and varicella are given between ages 4 and 6. And many of us are starting steroids in our patients typically around the ages of 3 or 4. And so we want to plan appropriately and make sure that our patients and that your children are protected prior to initiating steroids. And so we may recommend that you receive that second dose of varicella, that second dose of MMR a little bit early. And again, per the vaccine schedule, it's safe to give that second dose early. There just needs to be an interval of greater than 28 days between the first and the second dose. Some centers like ours may also test titers, specifically varicella titers, prior to starting steroids. To make sure that your child has mounted the appropriate immune response and that we don't need to give any type of a booster. I think oftentimes, you're receiving your vaccines at your primary care doctor's office. And so, we're all a care team. And so if there are questions or concerns, your neuromuscular care team, your pulmonologist can always connect with your primary care doctor to review some of these specific points. Next slide. Next slide. And so this is just highlighting sort of where the MMR and varicella vaccines are on the table. Next slide. And so once you're on steroids, again, we continue that you recommend getting all of your inactivated vaccines. And there's no need to adjust your steroid dose for regular inactivated vaccines. And as emphasized previously, you do want to avoid that flu mist, which is live, and opt for the shot, which is inactivated. And so if a live vaccine is necessary, and I would just like to emphasize this is incredibly rare. Most of those live vaccines you're getting earlier in childhood. And so this is a rare scenario, but you would want to wean the steroid dose to a threshold where you're no longer considered a highly immunosuppressed for at least a month before giving that vaccine and for at least a month after. Next slide. And so we get a lot of questions now that we have approved gene therapy product and multiple others in clinical trials about what do we do around gene therapy and vaccines. And so when we're giving gene therapy, that is revving up your immune system. I like to tell my patients that we're, pressing the gas pedal of your immune system if I give you gene therapy. The purpose, as we heard from Dr. Pham-Huy, of vaccines is to also help rev up your immune system, right? Help your immune system recognize and fight pathogens. And so if we give gene therapy and a vaccine in very close proximity, we are potentially sort of slamming on that gas pedal of the immune system, and we don't want things to sort of be in a hyper-inflammatory state. And so we generally recommend that you avoid any standard vaccines, including inactivative, for approximately 4 weeks prior to receiving any type of gene therapy, and then until you're cleared by your gene therapy provider after dosing. So that's usually for about 3 months after dosing or while you remain on high dose steroids. Um, as some of you may be aware, the planning process is intense, right? We're often doing screenings, checking all our other organ systems, we're submitting to insurance. And so this is a really great time period to ensure that you're up to date with your regular and your seasonal vaccines. So while that insurance auth process is in place, it's a great time to touch base with your pediatrician, find out if the seasonal flu and COVID vaccines are available, and go ahead and get yourself protected. Next slide. And so when we give gene therapy, again, to calm down that immune response that happens when we give the therapy itself, we are giving increased doses of steroids above baseline. So everyone who wasn't considered highly immunosuppressed then sort of crosses into that bucket of being more highly immunosuppressed. In addition, some of the clinical trials might also require a second or even a third immunosuppression agent. So, different medicines that kind of dampen down those immune responses that Dr. Pham-Huy reviewed. And so, that increased level of immunosuppression might make your child more susceptible to infections. And so vaccines, as we heard, can really decrease the risk of serious complications from infections and can offer that additional protection while you're in that heightened immunosuppressed state. And so your team may recommend additional precautions as well to help reduce that infection risk in the peri-treatment period. Next slide. And so one of the things that comes up is what are the requirements for vaccines in clinical trials? And anytime we're doing a clinical trial, we are studying to see if a medicine is both safe and effective. And so we always want to do things when we're studying something that's less known to improve safety and decrease the risk of serious side effects. And so while every trial has slightly different requirements in terms of what's needed to potentially participate, many trials may require that you receive your standard vaccines in order to screen in. And then some trials might have additional specific vaccine requirements based on the combination of immune suppression that's used. And so there's a drug that's sometimes used in gene therapy clinical trials and sometimes used to treat a rare and serious complication of gene therapy called thrombotic microangiopathy, called eculizumab or Soliris. And so eculizumab is what's called a complement inhibitor. And this top picture just shows you how complicated the complement system is in our immune system. It's one of those innate immune defenses that our body has. And so it's a part of our immune system that helps to fight infections, and it's thought to possibly be involved in causing thrombotic microangiopathy after gene therapy. And so what eculizumab does is it blocks one of the steps in that complement pathway to try to hopefully prevent the development of TMA. However, a complication of that, and this goes back to the risk benefit, is that it makes it so your body might not be able to effectively fight the meningitis bacteria. And so if a trial is giving eculizumab, you might be required to get the meningitis vaccine ahead of time. Next slide. And so in summary, vaccines are important throughout the Duchenne and Becker lifespan. The vaccine schedule may require some modifications around the time of steroid initiation and or with the initiation of gene therapy. And trials may have specific vaccine requirements, either based on the regimen of medications being used or based on other requirements. And so by staying up to date on your regular vaccines, it helps with potential eligibility. I think, the vaccines are so important in terms of, keeping our children safe. And similar to Dr. Pham-Huy, I'm a mother of young children and was so grateful when my children were able to receive their regular childhood vaccines. And with that, I will turn things over to Rachel for the Q&A.
All right. Thank you so much, Dr. Matesanz, Dr. Taylor, Dr. Pham-Huy. I see that we've got about 5 minutes here where we can dig into some questions. So if you have questions that you would like to ask our panelists, please feel free to go ahead and drop them in the chat right now, and we'll get through as many as we can. I think one of the things that I heard from the presentations was that, the plan for any individual patient is going to depend on a lot of different factors like their age, like their current vaccine status, like their steroid dosing. And so I wonder if we could just quickly review again, Dr. Matesanz, what those thresholds are as it relates to immunosuppression with corticosteroids. And maybe Dr. Pham-Huy, you can talk a little bit about this too. Like, what level do you need to be under, or how do you sort of figure out where you are as it relates to the ability to successfully receive a vaccination?
Yeah, so I think if you're on daily prednisone, it's if you're above 2 milligrams per kilogram of body weight a day, or if you're above a 20 milligram daily dose of prednisone. So, like I said, it sort of the threshold is around 60 pounds when you're going to hit that 20 milligram dose. For deflazacort, it's 2.4 milligrams per kilogram per day, or greater than 24 daily milligrams daily of deflazacort. And so that's a same weight threshold, about 20 or about 60 pounds. The standard doses that we're starting at are 0.75 mg per kg per day of prednisone and 0.9 mg per kg per day. So, and Dr. Pham-Huy can chime in, but that falls into kind of the lower dose immune suppression bucket. And so it's only after you're crossing that 20 milligram or 24 milligram threshold, or if you're getting the additional steroids around gene therapy, where you cross into that kind of high level immunosuppression bucket.
That's great. Dr. Pham-Huy, any additional insight you want to add?
Yeah, no, I think it's important to just have that concept of low level, high level. So in general, for low level, including all this dosing, like you can get your inactivated vaccine, you can get your live vaccines, the caution, because the safety is there, but for the live attenuate, that's when you have to tease out a little bit better what is the whole level of immune suppression. And so again, look for that window, because it does sound that there's a bit of flex. There are medical condition where you cannot change anything or it's innate. But in this condition, sometimes there's, after gene therapy, there is a period where the immune suppression should be decreased over time. And I just want to remember the audience that we focus a lot on the vaccine, but you have to remember that what we're trying to prevent are these infectious diseases that are unfortunately emerging or re-emerging. And so that is also something that we need to evaluate on a regular basis, because it's dynamic, right? Things might change. The risk of a child being exposed to measles or influenza or COVID might change over time. So it's always, you always have to have that balance in your mind.
Absolutely. And I think it highlights too the importance of the collaboration with your neuromuscular team, right? So oftentimes it's the pediatrician or the family practice provider who's administering these vaccines in sort of this primary care setting, but sort of that crosstalk between your primary care provider and your neuromuscular team, your neurologist, your pulmonologist, to really think through all of these different elements and any changes or shifts that need to be taken into account so that you can be safely vaccinated with that maximum efficacy, right, is really important. So when in doubt, ask your doctors, because they will surely be able to guide you. I think one other question that I see here is around timing of vaccinations as it relates to different types of stress on the body. Maybe there's illness, maybe there's weekend dosing steroids, maybe there's a broken bone. Is there any strategy that we should keep in mind in some of these different circumstances, or do we really just kind of defer back to that holistic view of that baseline level of immunosuppression?
I think Dr. Matesanz, had it in her slides. So for low level, again, don't try to time and just get it. I think is the simplest advice.
Awesome. And then I think there's one other question here that we can end on. I think, to think about the entire population of folks that are living with dystrophinopathy, whether themselves or a loved one, we've got folks who are maybe not on steroids or maybe have a clinical picture of Becker. Are there any take-home messages for that sort of segment of the population, our carriers, who might not have the same level of weakness as somebody with a diagnosis of Duchenne, and what could they take away from this?
So I think taking away that getting your regular vaccines as scheduled is still incredibly important, right? We know individuals with Becker can have heart problems and can have sort of subclinical breathing problems. And so it's really important that you get that protection as well, to help keep yourself safe.
Awesome. Well, I see that we're at the hour, and I wish that we had more time for questions, but unfortunately, we are out of time. I want to thank our wonderful panelists for joining us today, Dr. Pham-Huy, Dr. Taylor, Dr. Matesanz, for taking time out of your day and teaching us about the concept of vaccination and how it can be a useful tool to prevent complications from respiratory and other illnesses. And I want to thank everybody who tuned in and listened to these presentations today. We hope that you found this helpful. If you have questions that you still want to ask, please reach out to us. You can shoot an email to the PPMD care team at just careteam@parentprojectmd.org and connect with myself and my team, and we're happy to point you in the right direction. And also, again, be sure to check out the updated materials on our website that have been reviewed by our panelists today and updated nicely. And with that, we'll go ahead and conclude today's webinar recording. Thanks, everyone. Have a great afternoon.